welcome everyone. I'm Andrea Baccarelli. I'm the Dean of Faculty at the Harvard T.H. Chan School of Public Health. And I'm really delighted today to be joined here by Dr. Mandy Cohen, Director of the Centers of Disease and Control and Prevention, and also a Harvard Chan alum. Thank you so much for being with us today.
Thanks. It's great to be here. I was thinking I sat there, right? So I was remembering back to my first class. I'm pretty sure it's biostats.
Fantastic. So somewhere here is probably also the next director of the Center.
Yes, I love that.
We'll try to find out where they are. Let me tell you a little bit about Dr. Cohen. She has been a director at the CDC for just 1 year, a little bit over a year. Prior to that, she served as Secretary of the North Carolina Department of Health and Human Services, where she led the state's COVID-19 response and transformed North Carolina's Medicaid program. Before that, she also served as CEO of Aladate Care Solutions, which helps independent primary care providers, health centers, and clinics to deliver better care to patients. Dr. Cohen received her medical degree from the U.S. School of Medicine and her Master of Public Health here at Harvard Chan. We are so pleased to have you back today.
Thank you, sir.
To get us started, as the CDC director, what are you most proud of?
Well, great. So as CDC director, I want to back up. I wanted to reflect on a bit of time here at the school, which was amazing for learning, but I think more important, some of my best friends for my life I met here at the school. So in addition to getting enriched in your learning, make sure you're taking times to know each other, because they're going to follow you in your career and support you through different challenges and times of your life. One of my friends who's here right now, Jen Massa, we were together at Harvard School of Public Health, called the Chan School. Now we're dating ourselves. And it was just wonderful to have the opportunity to have that year to, it was during my medical school training that I came here for a year, and it was wonderful to sort of open my eyes to different kinds of opportunities for building a career. So it was wonderful. But when I think about what I'm most proud of in terms of being at CDC, is really thinking about how to change the organization to learn lessons from a historic pandemic. We've all learned a lot. The world is very different in 2024 than it was just before COVID. And so we had to embed some lessons learned, and we certainly saw a lot of the flaws in what our public health system had, whether it was our data systems being underfunded, siloed, unstandardized, or the fact that we weren't communicating rapidly and clearly enough. So what I've taken is lessons learned that from leading the COVID pandemic in North Carolina and tried to implement that at CDC. So I'm really proud, and I hope you are seeing that the CDC is working really hard, one, to communicate differently. CDC.gov is completely different. We archived 60% of the stuff that no one was looking at anyway. And we are trying to communicate fast, clear, say what we know, what we don't know, and to be engaging in how we communicate. Folks, I think you all consume your information and your news differently than we just did a few years ago. So we need to be disseminating information differently. So proud of how we're changing communications, but really proud of how we're changing the operations of how public health is operating. So changing our data systems, and I know we'll get into that, are making sure we have the lab capacity that we need, but that importantly, we are bringing the health delivery system and public health closer together. So I actually spent most of my career more on the delivery system side than in public health. Even though I had a public health degree, I was at Centers for Medicare and Medicaid Services. And you heard in the private sector as in the delivery side. And what we saw during the pandemic was way too much of siloed between public health and health delivery. And, a lot, because I think I had the opportunity to be on the delivery side, is to bring those worlds much closer together, knit them together with data, but then think about all of the tools that we have together to solve hard problems. On the health delivery side, we call that population health. In public health, we say community health. It's the same. And so we just need to make sure that we are using all of our tools in alignment together. And that is a culture change for us at CDC. So we are operating differently, moving from an academic research entity to a response entity that is plugged into the delivery system. And so I'm proud of that work that we're moving towards together, but still a lot more to do.
Thank you so much. That's really amazing. Let me move on to another question. Recently, 8 former CDC directors wrote an article, an opinion piece, reminding us that the CDC is not just about controlling pandemic and viruses, but is to save lives and protect Americans from all threats to human health. So how do you define the core mission of the centers, and what public health concerns specifically right now keeps you up at night?
Sure. Well, I think one of the things I'm proud of is that we were really clear in defining our mission at CDC, and it's to protect health and improve lives. I say this to our CDC team. When you go home for Thanksgiving, I want you to say, when your uncle says, "What is it that you do at CDC again?" You're waking up every day to protect health and improve lives. That is our mission, but we cannot do that alone at CDC. It is a team sport to do that. But that grounds us in what are we focused on. And what those past CDC directors were trying to articulate was this isn't just being about reactive to infectious diseases. That is table stakes for sure. We have to be fantastic lights out on that in terms of response to infectious disease, but that is not the only thing that is a health threat to our communities, to our country, to the world. And so recognizing that the thing that is killing folks under the age of 50 are suicides, overdoses. The thing that kills 2-year-olds to 5-year-olds are drownings, right? We need to make sure that we are being proactive about the many health threats, whether those are coming from mosquitoes or the heat, or from mental illness. The thing that still is the number 1 killer in the United States, heart disease, right? So we have to be thinking about all of those health threats, and importantly, that we have the core capacity to respond no matter what it is. If it's an infectious disease threat, we need data infrastructure, we need lab infrastructure, we need response. And if it's a heat emergency, we need data infrastructure and lab infrastructure and response, right? But what we had been doing for many years, no fault, but we've been investing in disease-oriented programs and infrastructure, right? So our malaria work set over here, and our COVID work was over there, and our HIV work is here, and I wonderful deep experts, but that means each of them had their own data system. Each of them has their own labs. Each of them has their own way to respond. Wow, that makes it really hard for those of us who sat at the state to interact with CDC, right? And so we're changing that drastically to be better partners, right? If we're going to actually achieve the protection of health and improving lives as a team, we have to be a better team at CDC first, right? And so that is a lot of the work that we have, but that link between infectious and non-infectious disease is so important. And I'm spending a lot of time making sure that communities see public health doing work for them, right? When public health is working, it's invisible, right? It's only when the things go wrong that it's in the news. And what we need to help everyone understand is make that invisible visible so that they're understanding the link between the non-infectious disease, the infectious disease, and the importance of investing in prevention.
Thank you so much. That's really interesting about making the invisible visible. Thinking about the topic that has been on the news a lot recently and in our own lives, I would like to talk about data.
Love it. Love data.
We all do. We all are preaching to the choir.
Yes.
Like many of your predecessors, you've been concerned or at least expressed frustration about how data are collected, stored, and organized across the US. Could you please explain the challenges you are facing and what it will take to overcome?
Sure. Well, data is the oxygen that powers our work. If we can't solve problems we don't see, we can't prioritize, we can't detect things quickly and respond. So data is so critical and foundational. Yet there was $35 billion through high tech that was invested in data infrastructure and the delivery system reform, and none that was put into the public health system. Now we've had about $3 billion put into data infrastructure in public health, CDC and state and local. So $3 billion to $35 billion, we're still a little behind. But we're making some progress on our data infrastructure, because I think it was on display during the pandemic. We were underfunded, but we were siloed, as I mentioned, and we were unstandardized. So we had 10 different ways of collecting race, ethnicity, gender data, and we didn't have it in standardized formats, and it wasn't interoperable. And so we have a lot of work to do. So we've been working to make sure that we could put data systems in that gives us the visibility we need. And I'm excited about the progress. Now, we have visibility into 90% of the emergency rooms in the country with syndromic data. So we can look in the rural parts of Texas where we first saw those avian flu cases earlier in the year, and we could say what's happening in those emergency rooms. And I could tell you how many conjunctivitis cases, and I could see how many respiratory illnesses were coming into the emergency room in real time, right, within 24 hours. Really important that we have that visibility. Not perfect yet, 90%, pretty good. We're also getting commercial laboratory data for the first time, de-identified, but hundreds of thousands of pieces of data every single day to understand what labs are being ordered, so you can look and detect, is there a cluster of flu lab tests being ordered in a particular part of the country? Why is that happening? That's a signal we could go after. So there's a lot of progress. Our mortality data is better, but we are making progress now on electronic case reporting. Again, these are standardized ways for us to transmit data. My first project when I was leading the COVID pandemic, so it's February of 2020, the first project was kill the fax, because in North Carolina, we were still receiving all of our lab data by fax that then needed to be inputted by hand into another program, which then was not yet interoperable with a third program, which is how we actually made our dashboards. Terrible. We obviously killed the fax very quickly, but we have now made this investment, but we need to sustain the work that we're doing and continue to progress in that. And so data is super important, but let me say one more thing, since we all love our data and we feel very connected to our data, particularly if we're the stewards of collecting that data. But data is a tool, it's an asset for us to keep this country safe. And that means not even my own team at CDC is it their data, it's our data, right? And so we need to make sure, even if you are the stewards of the data, you are not the owners of the data. And we have to make that data liquid, interoperable, so that we can link it to other data systems, so that we can best use it to protect each other. So that is a hard thing. We love our children so much. We need to let them go. And for that has been a challenge, and I hope to have partnership of my folks in academia as well, to make sure, even though you're the owners, the stewards of data, you're not the owners.
Thinking about letting go of these children, getting the data enter into the world, how about the way the CDC and public health in general communicates data and science to the world? What type of challenges you see there, and how you think about them?
Well, look, everyone is, as I was saying, they're consuming information differently. Everyone, it has to be, not just do we have to be accurate and fast and concise, we actually have to be engaging. That's how people are consuming their information. Engaging, another word for that is entertaining. And so it needs to be understandable. And you could see that in the way we're trying to display data in a much more easy to understand. Instead of tables and tables of data or complex charts and graphs, really trying to simplify visualization so people can feel like it's actionable for their real lives. Perfect example is that CDC is using wastewater as a new tool for detection. we had a team go in and really rethink how to visualize what data we were seeing from wastewater. Before we did that, I think we had about 100 very eager people who would use that data and come to it. Now we have 2 million people using that data and it becoming actionable for folks. So it has been a game changer just in visualizing it's the same data inputs, right? Just visualizing it different, as making it accessible to folks so that they can take action in their own lives, in their own communities, to think about what might be going on in their backyard. So I think really powerful in how we do the visualization of data and make it practical for folks. So another example, we often had our COVID data isolated from our flu data, isolated from our RSV data. But when someone gets sick in the winter, they just get sick. They don't know if they have COVID or flu or RSV. They're trying to protect themselves from all of those viruses at the same time. So they want to know, well, what's happening with respiratory illnesses in my community? And so for the first time, you're going to see that data. We combined RSV, COVID, and flu together last season. And then this season, you're going to see a new composite measure about respiratory illness burden in your community, which again, just gives folks simple ways to be like, what's happening around me? What should I be doing to protect myself and my family? So I'm excited for us moving in that direction to not just get the good data in, but then turn it around and use it to be very actionable for folks.
Fantastic. And a follow-up to this theme, we wouldn't be really in 2024 if we didn't speak about AI. Okay. So how are you thinking about AI? How is it being used or being planned to use at the CDC? What role you think it's going to have in the future of public health?
Sure. Well, look, I think AI is and will be a very powerful tool. I don't want to skip over the step that we have some just serious blocking and tackling to do on the data front to get the pipes, the standards, the visualizations right. But AI is already being put to use, I will say, at CDC. And these are where large language models and other opportunities for us to detect signal to noise, right? The whole thing is there something really happening here that I need to be aware of? And so how do we take inputs and signals and train these models to identify when something is actually a signal and not just a lot of noise? So we're already doing that in our Legionella work. When we look at some of our water towers and such, we're using it for large language models, looking at what people are Google searching. Why are so many people Google searching headaches in this zip code? That's a signal that we need to chase down. So those are ways in which I think AI can be helpful. And importantly, I think that public health needs to be at the table, defining the guardrails, making sure the use cases there are public health use cases in what these models are doing, because the private sector is certainly running fast to develop opportunities. The health delivery system is. I worry public health, we will once again be left behind if we're not at the table leaning forward. That means the data inputs have to be really good, right? If we don't get the blocking and tackling right on the front end, AI is not going to be of any use. So we have to catch up, and we have to be at the table and make sure public health use cases are part of the thinking. And I think there are plenty of very good ones, but I think we all need to make sure at tables where all these conversations are happening, that we put ourselves at that table.
Fantastic. Thank you so much. I would like to move now and asking you to reflect back about your time as the public health director in North Carolina. Mm-hmm. And as I mentioned before, you started a new program there, very innovative, where Medicaid tackled the social determinants of health. For instance, that meant that Medicaid would pay for things like nutritious food, transportation to medical appointments, and even home renovations, like making an apartment or a unit wheelchair accessible. Mm-hmm. What did you learn from that part of your career, and how is that now influencing you in your current role?
Sure. Well, I was very lucky in North Carolina. First, I was new to North Carolina when I joined. I'm not from there originally, but I feel like I'm from there now, and you can hear I have like a little twang that can't get rid of it. So I say North Carolina. So, but I was very lucky to be not just the public health director or the Medicaid director, as Secretary of Health and Human Services. I had the opportunity to, within that department, to have Medicaid, public health, mental health, all of the social services, TANF, SNAP, as well as early childhood education. And it's really powerful when you can think about the collaboration and synergy between the programs. And so we asked ourselves as a leadership team very early in my tenure to say, how can we bring all of these levers, Medicaid levers, as well as the social services levers, early childhood, public health, together in service of our communities? And I think North Carolina was really well positioned to really think differently, and that's what we did. So one piece of that puzzle was using our Medicaid lever to say, well, what should Medicaid pay for if you really want to keep people healthy? And it's not surprising that if you look at some of our most high-risk Medicaid beneficiaries, it's housing insecurity, food insecurity, transportation, and we have a very high rate of interpersonal violence. So those are the factors that were driving a ton of healthcare spend. So we said, well, let's ask CMS for permission to spend on the things that will actually keep people out of the hospital, out of the emergency room. We particularly focused on pregnant moms, right? Short period of time to show outcomes. And most of the NICU dollars spent in North Carolina are spent from the Medicaid program. So we had an immediate way to say, could we, if we are keeping mom healthy so she didn't have a preterm birth, are we keeping kids out of the NICU and saving dollars on the health delivery side? So again, but it took a team effort that couldn't have happened with public health alone or Medicaid alone or social services alone. It really was a team effort, but we used some of the authority and power of the Medicaid 1115 waiver to do that. They implemented the program, and super proud. That program we implemented through the COVID pandemic, which actually gave us more tools for our state. It was really fantastic. And the first year of evaluation was in, and not only were we able to get services for people, get them food security, housing stability, but it saved money. It worked. So it was about $88 less per member per month for those who were enrolled in this program. So really huge. Plus, the money that went to spend on housing or food services went to local nonprofits. So it was an economic generator as well. So I'm a big fan. Check it out. Healthy Opportunities, North Carolina. There's been a bunch of papers written on it. Medicaid now has been approving these types of waivers in other states. Other states are taking it to the next level, which I love. But I think that is the future when we talk about where public health needs to go. My biggest advice to you as folks who are building your career in public health is to make sure you understand how are things measured, how are they paid for, and how they operationalized, because that is the way you can sustain the kinds of investments and impact that you want to see at the community level. And so that was a great way of mapping public health principles to the practical levers that were in Medicaid and using tools through social services, right? So one of the biggest learnings, again, from the NAT that we saw is that folks were not signing up for SNAP, the nutritional program, even though that they were eligible. Turns out it's tough to fill out a SNAP application, but instead of paying for food delivery, if you just have someone help them fill out a SNAP application, that can be really low cost intervention. So those are a lot of learnings. And again, things that don't always surface unless you're looking at multidisciplinary teams to try to solve hard problems.
Thank you so much. I would like to move to a different topic. The Surgeon General recently has called for policy changes to make social media safer for children. So do you see social media as a public health risk? And how would you like tech companies as well as policymakers to move forward with this?
Yeah. Well, this is a very active conversation in my home. I have a 10-year-old and a 12-year-old, both who don't have phones, and they're going to tell their therapists about it when they're older. But it's going to be fine. But in seriousness, look, I think all good rules are neither all good or all bad. I think there are some benefits of both having the phone in terms of social connection. Don't tell my 12-year-old who doesn't have a phone yet, and that there are important pieces of how social media can give positive messages. But we all know of like the dark side, the negative side of one, the addictiveness of what screens are and the social media, as well as particularly for young girls, serving up images and messages that can be damaging to their self-image. So it's not an all or nothing. And again, I think this is a place ripe for research. And stuff that we are doing right now. So I do think, though, that this isn't about never, but it's about how. How do we move through this in a safe way, and focus on that, focus on safety, and try to maximize things that are benefits. And it starts at home. Like I wasn't joking where I said this is an active conversation at home, because it does have to start at home, and me getting off of my own phone so that I'm at home and with the kids. And so I think some of it's, role modeling, having that discussion, making sure your kids are aware of those issues, but then it does need real research to understand what are the guardrails, parameters that we need to put around some of these tools, and what are the regulations that are needed. But we need to inform those regulations with data, and I still think we're a bit data free in where we are. So more research to come.
Thank you. So I see here a lot of students and trainees, and many will be online. So I wanted to ask you, I'm sure everyone is curious to hear about your experience here and how that has been a trainee in our Master of Public Health, and how that has shaped your career path, and how did you get from being a student in this classroom to be your current role?
So, well, that's a hard question to answer, but what I'd say, I want to go back to the relationships. And so, yes, I was talking about your colleagues and friend relationships, but I still have mentors, teachers who I am still in touch with, who I met here and through my year at Harvard School of Public Health. One of whom I saw last evening, David Blumenthal, who I met because of the program here. And I was able to interact with folks who have built a career working in the public sector, as well as academia, as well as the private sector. So that was wonderful. It also opened my eyes to health services research. I had never thought about it. So it was the first time I met Don Berwick and heard about how do you think about the operational pieces, right? When I talked about measure, pay, operationalize, a lot of what Don's work, when IHI's work is really about how to operationalize things. So those were all, I love thinking about what you pay for and how that changes behavior, what you measure and how that changes behavior, and how you operationalize and change behavior. That my eyes are really opened to all of those concepts here. And so I was always very interested in those intersections. So it's not surprising I went to CMS before I went to CDC. I was really interested in the payment side, the measurement side, the operational side. And I'm thrilled that I was able to do that, but I always took with me those public health principles, right? It's measurement in service of making sure our individual families and communities were healthy. And how do you think about both? And it's not surprising that I wanted to pay for the health of communities in addition to keeping individuals healthy. So the first things I worked on at CMS were accountable care organizations, right? So how you pay matters to the outcomes that you get. So that's always been a guiding light. And I will say like I said, the mentors that you get here, but make sure that you reach out to other schools, whether it's the medical school. I took classes over at the Kennedy School. I still think about the polling classes that I went to about what do real people think, and then how do they react to different situations. It really helped me be a better communicator about some of the different topics that we have. But so take advantage of being at Harvard. So many resources, so many for speakers to come in. Spent a lot of time at IOP, like over at the Kennedy School, seeing like the various government officials who would come in and talk about their leadership. So just take advantage of this time. It's so valuable, and you will miss it when it's gone. I know it feels hard at the moment, but it's actually not. And so you will miss it when it's gone, and the opportunities that are here.
Of course, you're all welcome to come back at any time while you're gone. So let me ask you a question. I mean, I can't think about in your role how much pressure and being an object of course often of criticism and having to navigate relationships with different stakeholders, politics, and all around that. How do you do that? Any information you would like to share?
Well, I was lucky to have a number of bosses who were great at relationship building, really, really prioritized relationship building. And I got to watch them navigate tricky relationships and how to really build intentional partnerships and relationships over time, whether that was with elected officials, with, at CMS, we challenging stakeholders of hospitals, doctors, insurance companies, pharma, right? A lot of challenging relationships, and watching some of my mentors and bosses navigate that gave me a lot of skills, so that when I arrived in North Carolina, completely new to the state, I knew that relationship building was going to be so important to introduce myself. So I spent a lot of time with the legislature introducing myself, but also just saying, what's top of mind for you? What are you most worried about in your community? And to try to find consensus. So you often will see on social media or whatever, like that there are places of disagreement, but there's actually a lot of consensus underneath the surface, and that's what I search for. And I went to North Carolina specifically because I was interested in working in a place that was politically divided. I worked for a Democratic governor, but we had a super majority of Republicans in the legislature. And it was a pretty weak executive branch, which means I couldn't do my work without the legislature. And so really prioritize relationship building there, finding the consensus. One of the first things we worked on in North Carolina was the opioid crisis, because that's what I heard. I said, what are you worried about? And they're like, my niece died of an overdose. My friend's son died of an overdose. I was like, we got to work on this together. And we started there. And we showed that we could work together across the aisle on something. And then it allowed us to work on the next hard thing, which was transforming the Medicaid program. And then it was implementing healthy opportunities. And then it was addressing COVID, right? So by the time we got to COVID, I had 3 years of relationship building, of trust building, of showing that I was a good listener, of trying to, find those consensus points, so that when we got into COVID, we had relationships that were built, but that I really focused on transparency. And this is a place that the governor who I work for, who is just the best governor, best boss I could have hoped to work for. He was very big on transparency. We did a press conference every day, 2 p.m. Anyone from North Carolina? We're all right. Yeah, right. Sorry. We couldn't get rid of us, right? It was like, really, enough already. But we really prioritized transparency and being the consistency of trying to share what we knew, when we knew it, what we didn't know. And I think that really allowed us to maintain those relationships, right? So it wasn't that I went into some dark office and then came out with some magic numbers, and everyone was seeing the same numbers that we were looking at, how we made decisions every day. They didn't always agree, right? It's not about always finding that we're always going to agree, but at least they understood why we were making the decisions that we were. And I think it allowed us to stay united as a state. And I was really proud. We got 99% of our seniors vaccinated in North Carolina, right? That's a politically divided state. 99% of our seniors. Governor was never stripped of his powers. I kept my job until I wanted to leave. So these are success metrics I'm really proud of. And as far as turning out the negativity, there's always going to be the haters. I just channel Taylor Swift, shake it off. So there's always going to be that. Going back to the social media question, for my own mental health, just candidly, I don't have social media on my phones. I have a wonderful special assistant, Abby, goes somewhere. Oh, she just went away because she's busy. But she posts for social media for me because like I've decided for my own personal mental health, like I don't need to like see all the haters. But I do want to get feedback, right? And so you want to make sure you're getting the balance of like when folks are being negative toward you, I really, really try to like channel to be like, where is that coming from? What's underlying that? Is it fear?
Yes.
Is it a true disagreement at a intellectual level? Is it a misunderstanding? Is it that we, CDC or whatever job I had at the time, are not being clear enough? So I really try to not get defensive and say, where is that coming from? How can I be better to address this? It doesn't mean I change my position necessarily, but at least I can explain why. It helped folks understand why I got there and say, look, we can disagree on this, but I hope you at least respect that I heard you. Let me repeat back that what I heard from you and why we can't do the thing. But then there's some just haters out there that are going to, hate and then like shake it off. Thank you, Taylor.
That's really impressive. I think we should print your words and put you at least on my wall. Then.
Well, don't. Taylor would be mad if I stole her words then.
Okay. We asked everyone when during the registration for this event to send their questions. So if you don't mind, I'll move on to the questions from the audience. And I start from a question from Kiwi. Do you think that basic science and translational researchers should get more involved in public health conversation?
Well, the short answer is it's a team sport. So it's sort of a bit of like, what do you mean by get more involved? What I think we absolutely are going to need deep researchers who are going to spend their time in their lab and be the experts on a particular bug. So don't take anything away from that kind of expertise. But another important type of expertise is communication expertise. So I don't expect necessarily everyone who's sitting at the bench all day to be fantastic at communicating. I do expect them to respect that communication is a skill and that if they haven't built it, to partner deeply, right? So your lab should have a communicator as part of the team, right? Or your division or your brand like has to have someone and respect that there is an expertise and in the communicating as much as there is expertise at knowing which reagent or which we're going to use for something. So just respecting that discipline. And actually, I'd like to see more as I talk to folks who are thinking about academic curriculum is thinking about how do we up the bar on what is expected from a really outstanding public health communicator, and what is the bar for that? How do we really teach really good writing, really good clear communication, and to make sure that we recognize that that's not going to be everyone, and that's okay, but it's not okay for you not to have that skill set on the team.
Thank you. The second question is from Elena. What is your advice for state and local public health agencies on how to prepare for H5N1?
Well, okay, avian flu. What I would say is state and localities have been preparing for avian flu for decades. This is a place I am super impressed with the depth and maturity of the preparedness in the flu space. Folks have been thinking about pandemic flu for a long time, and it shows. It is why when we had our first cases of avian flu from new exposure to cattle, that we were able to have answers about the genetics of what was happening right away. We have treatment, we have tests, we have vaccine candidates. The flu team at CDC is unbelievable. They are so good at their job. And I think states and localities are excellent at what they are doing. Now, we need to sustain that work. I think the biggest challenge has been in the trust building. So the trust building with our dairy farmer colleagues. We've been working with poultry farmers, right, which is where Avian started with our chickens, right? We've been public health has been interacting with poultry farms for many, many years to keep workers safe, to identify avian early. But dairy farmers and public health were new friends, and it's going to take time to build trust. And so actually the things that state and localities, places that are doing it well, really are leaning into how do we build trust right from the get-go, and they're making that foundational. But trust takes time. And right when you're fighting or worried about a pandemic, that is a thing you don't have. And so my advice is thinking about how do we really work on trust building ahead of an emergency. Luckily, Avian is not an emergency. We have that time, and we're trying to invest in the trust building, whether it's good communication or meeting our dairy farmers where they are, which is they're less worried about the impact of avian on their health. They're worried about their own mental health. They're worried about suicide, actually, in their workers. And so we as public health practitioners, we need to hear that. Maybe our priority is avian flu with that population, but their priority is worried about mental health, addiction, suicide. And we have to bring our resources to bear to help that community, again, as a trust building exercise, so that when we want to work on avian together, we have that foundation of trust.
Thank you so much about that. The next question is from Stephanie about trauma. How does trauma-informed care fit into today's public health landscape in the US and beyond?
Yeah, a really important question. So about trauma-informed care. So we have 3 big priorities at CDC: being response ready, improving mental health, and then the third is supporting young families. And I think this is where trauma-informed care comes in, because we are really focused on the adverse childhood experiences that we know our young ones are coming into contact with. And the thought of is, how do you help them be resilient through that? How do you recognize that kids are going through trauma, that adults are going through trauma, and in your care, you are identifying that and helping folks be resilient? Because we're never going to stop all the hard things that happen in the world, but what we can do as practitioners is potentially help folks be resilient through it and to foster more positive childhood experiences. So I think that is a place where we are also collecting data from a CDC perspective. So I'd encourage you to look at our resources on adverse childhood events and thinking about how we think about trauma-informed care as part of that.
Thank you so much. There is then a question from Megana, which probably you have already touched upon, about North Carolina and what you did and learned in North Carolina, whether and how much you have been able to apply it now at the national level. Feel free to give it.
Well, yes. So to maybe touch on North Carolina again, I think there were 3 core things that I brought from North Carolina's COVID response to the CDC. One you heard about, which is transparency in communication, right? That making sure that you're transparent, like that builds trust. Second is building relationships. I keep going to that. Relationships are so critical. We're all just humans. And so thinking about how you build relationships, and really that's more than just sharing information. That's about trying to plan a shared goal together and then achieve it. And then lastly, I think this is so important. It's about good operations. And what I mean by that are good execution, right? You can't just recommend a vaccine and be like, I'm done here. My work is done. I've recommended a vaccine. You actually have to think about every step in the process of how that vaccine goes from getting made to getting on the shelf to getting into an arm. That's the work, right? And that's operational work. And because you can say, I recommend, but if there's no vaccine in my neighborhood, or I can't get to that vaccine, or if there is a cost barrier, a transportation barrier, a stigma barrier, what have you, work's not done yet. And that doesn't build trust, right? And that's where trust gets broken. You said you want me to get a vaccine. I don't have that tool. You're ignoring me. I don't trust you, right? And so how do you think about building trust by thinking about good execution? So got to be transparent and communicate well. You got to build a relationship, but then you have to think about the operational part and operational excellence. And so I would love to see more skill building in public health around understanding the operations and getting into those kinds of details, because I think that's so foundational to trust, showing up and doing the work and doing it well. But it takes that is a particular skill to build, and one I had to build over the course of my career.
Thank you so much. We are taking notes.
Okay, good.
A question from Nancy. What steps are you taking to ensure programmatic priority and funding needed to support work concerned with equity, including in relation to racism, reproductive justice, LGBTQIA+ rights, and disparities?
Great. Thanks, Nancy, for the question. I feel very privileged at CDC to work at an organization that is really, really, really in tune to equity. I mean, I think it is at the core of public health and our values. And I see that playing out every day. And so I want to go back to the things that I think build trust and help reach to marginalized communities. And that's relationship building, good communication, and operations. And that I want to emphasize on the third, the operations. We can't just talk about equity. We can't just admire a problem by collecting data. We actually have to think about what are all of the operational barriers that are in the way here. We know they're structural, right? We talk about the structural barriers that we have. And so when I hear that question, I just want to articulate that the funding, right, isn't just what funding is going to an Office of Health Equity. That should be core funding for the entire response enterprise, right? Because if we're doing it right, we're getting to every zip code, every community, and we're building trust everywhere by doing good execution and operation everywhere. Now, you both have to build that foundation and call it out specifically. So I'm not saying you can't have an Office of Health Equity who is thinking about those kinds of issues all the time. But if you don't have it built into every part of your organization, so when I'm thinking about on the Hill and thinking about resources that we need, well, we ask for good operational resources, or we are working right now to try to get a vaccines for adults program, right? Doesn't have the word equity in the title, but is absolutely an equity program to make sure that every community is not left out of our ability to operationalize vaccines, right? So we very much, it's just so embedded into all the things that we do, but we both have to call it out separately. We got to measure it, and then we got to execute on the operations in order to close the disparity gaps and build the trust.
Thank you so much. We only have 1 minute left, but being my background in environmental health, I can't help reading out a question from Cecilia about climate.
Okay.
And Cecilia asks, what initiatives does CDC lead in addressing climate-related sustainability issues?
Yeah, I think climate has an enormous impact on our health. So CDC for the first time put out a health heat risk index this year, and so tried to give some easy tools for folks to say when 90 degrees in Miami is not the same thing as 90 degrees here in Boston. And so what do we want folks to know about? So it's more than just temperature, but there's heat risk depending on where you are in the country. And then there's certain clinical indications if you take certain medications, if you're a child with asthma, if you're a pregnant mom, that you want to be taking. So one is first to everyone recognize the connection between heat and health. So that's one. Second, mosquito-borne diseases are really something we are watching extremely closely. They come in waves, and so we're actually seeing a bit more dengue this year, but less West Nile. We're seeing a new mosquito illness, Oropouche, where it was endemic to Brazil, but now we're seeing a big outbreak in Cuba. Oropouche is something that's acting similar to Zika, with potential vertical transmission, meaning from mom to baby, and having a potential impacts. We're trying to learn more. Either way, mosquitoes are living longer because the seasons are longer. We're seeing more hurricanes and more storms, which means more standing water. They love it. They're loving it. That's not great for us. So we need to stay ahead. We're trying to innovate in so many ways around vector-borne diseases, whether it's different ways of innovative ways to think about vector control or mosquito control without pesticides. So there are some great new things on the horizon. But also on the clinical side to make sure that we can have as much supportive care. We often don't have treatments or vaccines for many, many of these diseases and needing to stay out of them.
Thank you so much for those thoughts and reflection. Unfortunately, I have to say our time is coming to an end. So I'd like just to thank you again for being with us. This has been phenomenal. I learned a lot, and that's why we are here. We're all here to learn, including me.
Great.
And I want just to thank you again for being with us. Thank everyone, and have a good afternoon, everyone.
Thank you. Thanks,